questions which have been asked in the previous years. And if you look at the pattern followed by INICET, we have been studying the pattern and we see that traumatology is one of the topics that has been frequently asked. So in this 1 hour, I would be discussing and important aspects of dental traumatology, endodontic traumatology, management, etc. So a brief review to it. So I hope I am connected with you all. Let us start. I would be discussing. Step ahead. I don't know. We talk about endodontic traumatology. See, basically, traumatology means the clinical management of cases of tooth trauma or dental trauma. There are 4 categories of trauma. Basically, 4 categories are there principally. The first one and the simplest one are the crown fractures. The second category of dental trauma are the combination of crown and root fractures. Both crown and root are fractures. The third category involves the root fractures, and the fourth category of dental traumatic injuries, they are the luxation injuries, and avulsion. So these are the 4 principal category of dental injuries which happen. Okay. If we talk about the crown fractures, they are the simplest type of dental trauma. They are further divided into 3 subtypes. The crown fractures. One is infraction. Crown infraction, the simplest type of trauma. I would say it is a form of concussion injury in which there is no loss of tooth structure which is happening. Simply a craze line develops inside the tooth. There can be a craze or a crack. 2 forms of infraction can be there. A craze and a crack. Okay. What is the difference between craze and crack? Craze is a small, I would say, a very small incomplete fracture which happens only involving the enamel mostly and at times extending up to the dentine also. A crack, on the other hand, extends very well inside the dentine, involving major thickness of the dentine, of course, with the enamel also. So, craze and crack, they are form of enamel injuries which may involve the dentine at times, and they together constitute infraction, crown infractions. Then there are second category, that is uncomplicated crown fracture. Uncomplicated crown fracture. As the name indicates, uncomplicated crown fractures, they involve the enamel and dentine. There is loss of tooth structure which involves enamel and dentine, but there is no exposure of dental pulp. Since there is no exposure of dental pulp, it is called uncomplicated crown fracture. And as a whole, if we talk about all forms of dental trauma, uncomplicated crown fractures, they are the most common dental trauma. So what are the most common dental traumatic injuries? They are the uncomplicated crown fractures. They constitute 1/3 to 1/2 of all dental trauma. Cases of dental trauma. Okay. And the third category of crown fractures, they are complicated crown fractures. Complicated crown fractures. As the name indicates, complicated crown fractures, due to trauma, there is exposure of pulp. the pulp is involved in this. Pulp exposure happens. So complicated, as the name indicates, there is exposure of the dental pulp. If we talk about the brief treatment modality for these different types of crown fractures, then craze lines or crack lines, which are the crown infractions, principally speaking, they do not require any treatment because they are asymptomatic. Only some form of very less invasive procedure like dental veneers can be given if there is an unsightly, unesthetic appearance of craze line and which involves one of the anterior tooth. Otherwise, no treatment is required. If we talk about uncomplicated crown fractures, complicated crown fracture which are involving the enamel and dentine, then we have to treat the teeth in two aspects. Because the dentine is involved, we definitely have to treat the tooth. So suppose this is a crown of a tooth. This is the pulp organ. Okay. And the dentine all over enamel. So there is a fracture or trauma, loss of tooth structure, which involves the enamel and dentine. Okay. So definitely when the dentine is exposed to the oral cavity, the dentinal tubules are exposed. So the first goal of treatment in such cases is to seal exposed dentinal tubules. Okay. One has to seal the exposed dentinal tubules. And the second approach towards treatment is when the remaining dentine thickness is assessed. The most critical factor would be assessment of the remaining dentine thickness. If it is less than 0.5 millimeter above the pulp, we have to do pulp capping with some protective agent like calcium hydroxide or MTA and similar materials. So these are the two treatment modalities or considerations for uncomplicated crown fractures which involve enamel and dentine. Talking about the complicated crown fractures, which are involving the pulp, exposure of the pulp happens. This is the crown of a tooth. This is the pulp organ, the dentine, and the enamel. So there is a fracture of the tooth structure which is exposing the pulp. So the treatment considerations depends upon factors like first, time between trauma and treatment. The most critical factor is time between trauma and treatment. How much time has elapsed since the fracture has occurred and the treatment is rendered. The second consideration is the maturity status of the tooth. Maturity status of the tooth means whether it is a tooth with closed apex or fully formed tooth or with immature apex tooth, open apex or immature apex tooth. And the third treatment consideration for complicated crown fractures is concomitant periodontal injury. What is meant by concomitant periodontal injury? Whether there has been some PDL damage or not. If PDL damage occurs, then what happens? The tooth becomes mobile. There is mobility in the tooth. Not only a fracture is occurred, but mobility in the tooth. So some form of splinting would be required for such teeth where the mobility has occurred. So these are the three principal considerations we give. And the most crucial, as I've already told, is time between trauma and treatment. See, because the time when the time is between 24 hours to 48 hours, even though the pulp is exposed due to trauma, inflammation is superficial. The pulpal inflammation is superficial. Superficial means only limited to depth of 1.5 to 2 millimeters. So whatever pulp is exposed only 1.5 to 2 millimeter down, it would be inflamed. So we can very well save such pulp. There's no need to do pulpectomy when the time between trauma and treatment is within the range of 24 to 48 hours. When the time is more than 48 hours, okay, there is deep pulpal inflammation. The pulpal inflammation progresses deeper. Okay. Deep pulpal inflammation occurs, and whenever there is deep pulpal inflammation, we have to do pulpectomy. So this is how we decide the treatment for crown fractures. Now we talk about root fractures. The root fractures, they constitute about 0.5 to 3% of all dental injuries. Okay, 0.5 to 3% of dental trauma cases, root fractures. So if there's a tooth over there, the root of the tooth, these root fractures principally that we talk about are horizontal root fractures. Okay, the root can be divided into three aspects: the coronal one third, the middle one third, and the apical one third of the root. So depending upon the location, the root fractures, principally the horizontal root fractures, they are classified into coronal, middle, and the apical one third. The second category of root fractures are vertical root fractures. Vertical root fractures, they are non-treatable conditions. If a tooth is suspected of having a vertical root fracture, the best treatment available for that is to extract the tooth, because there is no means by which we can retain the tooth in a healthy position inside the oral cavity. So principally, we would be discussing about horizontal root fractures, and depending upon the location, the prognosis of horizontal root fractures is affected. Means the best prognosis is for the apical one third, and worst prognosis is for the coronal one third root fractures. Okay. Now, whenever the root fracture occurs, always root canal is not required. It is important to note that in all cases of root fracture, the root canal is not required, because it has been reported that pulp necrosis, it occurs in okay, the pulp necrosis occurs in 25% cases only. So whenever the pulp necrosis occurs, we have to do root canal treatment. So pulp necrosis occurs in 25% cases only. It is important to note that. But whenever there is root fracture, there would be increased tooth mobility. Isn't it? And to manage these increased tooth mobility, we have to do splinting. What are the protocols for splinting? This is another important thing which is asked frequently in your examinations, the splinting protocols for various cases of tooth trauma. And if I talk about splinting protocols for root fractures, previously the recommendation was splinting for 2 to 4 months. So in some of your old MCQ books, you would find the answers for the splinting, that is 2 to 4 months for root fractures. But now this concept is no longer validated. The International Association for Dental Traumatology, the international body which governs the cases of dental trauma, recommends 2 to 4 weeks, not months, of semi-rigid splinting. Semi-rigid splinting, 2 to 4 weeks of semi-rigid splinting. What is the meaning of semi-rigid splinting? It is sometimes also called flexible splint or physiological splint. So these different terms can be used, and you have to always remember that it is never rigid splinting, because rigid splinting leads to tooth ankylosis. We have to allow certain physiological movements to the tooth, and it is a form of semi-rigid splinting for 2 to 4 weeks. Only exception to this period is cervical root fractures, cervical one-third root fracture, where we have to splint the tooth for up to 4 months. So there are questions on both these things. Do not get confused. Just read the question properly. If it is asking specifically for cervical one-third root fractures, then it would be the duration of splinting would be 4 months. If it is simply asking the duration of splinting for the root fractures, not specified apical, cervical, or middle one-third, then stick to 2 to 4 weeks. Definitely the rigid splinting is not there. It is always semi-rigid, flexible, or physiological splinting. Okay. Diagnosis of this root fracture. We usually take intraoral periapical radiograph at 3 angulations. Straight on 90 degrees, 110 degrees, and 45 degrees. 3 different vertical angulations we take the x-rays to diagnose the existence of a horizontal root fracture. So these are the first, second, and third vertical angulation, and the fourth is an occlusal radiograph. Occlusal radiograph. So principally speaking, there would be 4 x-rays to determine the location and exact diagnosis of root fracture, 3 horizontal angulations, vertical angulations, and 1 occlusal radiograph. What are the angles? 90 degrees, 110, and 45 degrees. There have been questions on all these things. These are the important aspects of root fractures. If we talk about the treatment modality, the first thing that we have already seen is splinting, the first and the foremost thing. Secondly, we would do the pulp testing. As I have already told you, that in only 25% cases of root fractures, the pulp necrosis occurs. Okay. So pulp testing, it gives necrotic pulp. Then we have to do root canal treatment. Okay. And another important aspect is this. Suppose this is a tooth with horizontal root fracture in the middle one-third, and the pulp has become necrotic as is seen by different pulp testing methods, and the treatment is root canal treatment, then RCT would only be done in the coronal portion. This is important. RCT would only be done in the coronal portion. So we would do root canal in this portion and seal the tooth from above and do nothing with this portion. Suppose this portion is also necrotic and it develops a periapical lesion over time, then we have to do surgery for this. What is important to note that orthograde means the regular from the crown to the root canal is never done through the fractures, because if we are putting our file through the fracture, due to the gap in the fracture line, whatever intracanal medicaments and irrigants etc. we would be using would seep through the fracture line and go into the periapical tissues. That would result in inflammation and bone resorption. So root canal procedures are only done in the coronal portion or the proximal portion. If there is a wide canal present over here and regular obturation is not possible, we can even do apexification in the coronal portion. Okay. These are the treatment modalities. So splinting is required in almost all cases. What is the duration? I have already told you. And pulp testing would result whether the pulp is necrotic or not. And if it is necrotic, we have to proceed with the root canal treatment. If there is a apical one-third fracture, most of the time, no active treatment is required because the tooth remains vital and asymptomatic. Okay. and no active treatment is required in majority cases of apical one-third root fracture. As I've already told you, the prognosis is best for apical one-third root fracture, so no active treatment is required. That is important to note for apical one-third fractures. Okay. Now, outcomes. What can be the outcome of treatment of horizontal root fractures? There are four radiographic outcomes that can be seen on the X-rays. The first is healing with interproximal calcified tissue. Means we have done treatment for the horizontal root fracture and we want to assess the healing after a couple of weeks. The healing, if occurs with interproximal calcified tissue, then what would be seen on a radiograph? You would see a thin radiolucent line. The fracture line would always be visible, but it would be a very thin radiolucent line with well apposed fracture segments. With well apposed fracture segments. Okay. The second is healing with interproximal connective tissue. The calcified tissue is not forming, but connective tissue is formed between the fracture segments. Then what would be visible on the radiograph of such case? We would see thin radiolucent line. Again, a thin radiolucent line is available. On the follow-up X-ray, a thin radiolucent line is visible with important diagnostic feature is rounding of corners of fracture segments. Rounded corners. Both the proximal and the distal segments would have rounded corners, which is diagnostic of healing taking place with interproximal connective tissue. The third pattern of healing that can occur with treatment following horizontal root fractures can be healing with interproximal calcified. See, I'm using the word calcified because we do not know what type of tissue forms. It can be either cementum, bone, and very less likely dentine. All these are calcified tissues. So it is always better to use the term calcified tissue because histopathology is not done. We simply see a radiopaque tissue and the diagnosis is made only on the basis of radiographs. So healing with interproximal calcified and connective tissue both. Healing is occurring with both interproximal calcified and connective tissue. A distinct feature is this. There would be a radiopaque ridge, radiopaque disc between fracture segments. We see a radiopaque disc between fracture segments. So instead of one, there would be two fracture lines visible and a radiopaque disc between fracture segments. Indicates healing with interproximal calcified and connective tissue. And the fourth pattern, the fourth outcome that can happen following treatment of root fractures is interproximal granulation tissue formation. Interproximal granulation tissue formation. Whenever interproximal granulation tissue forms, it means there is failure of treatment. And such teeth would definitely need an extraction because the root fracture treatment has failed due to formation of interproximal granulation tissue. Granulation tissue indicates there is formation of chronic inflammatory tissue between the fracture segments. Radiographically, how it would be visible, there would be a thick radiolucent line. There would be a thick radiolucent line, okay, between the segments, and there would be widening of PDL around the fracture. The first sign and the second sign is widening of PDL around fracture line. So this is how, on the basis of follow-up radiographs, we can decide whether the treatment has been successful or not in cases of root fractures. And mind it, I am discussing about horizontal root fractures because vertical root fractures in all cases require extraction. There is no definite treatment available for them. Then there are luxation injuries. Luxation injuries, there are principally 5 types of luxation injuries. The first one is concussion. The second one is subluxation. Third one is lateral luxation. The fourth one is extrusion. And the fifth luxation injury is intrusion. These are the 5 principal types of luxation injuries. As the name indicates, luxation injuries, okay, from 2 to 5, there would be some mobility in the tooth and would certainly require some splinting protocol to be followed. If we talk about severity of luxation injuries, then the severity increases from 1st through 5. So which is the most severe form of luxation injury? Intrusion. Which is the least severe form of luxation injury? Concussion. Severity increases from 1 through 5. Okay. So if we have to distinguish between the clinical features of these type of luxation injuries, 3 things we would talk about. One is displacement of the tooth. Okay. Mobility of the tooth and percussion pain. Pain on percussion. 3 clinical signs or symptoms we would look for. In the cases of tooth concussion, there is definitely no displacement of the tooth. Hardly there is any mobility in the tooth, but there can be pain on percussion in a tooth which has undergone concussion. Subluxation, as the name indicates, definitely there is no displacement of the tooth, but there is increased mobility and there is pain on percussion. Lateral luxation, there is displacement of the tooth. Okay, but there is no mobility because the tooth has laterally exited. It has become lodged either in the buccal, the palatal, mesial or distal wall of the socket. So it is important there would be no mobility, but tooth displacement would be there, and there can be or cannot be, may or may not be pain on percussion. Extrusion, displacement of the tooth has occurred. There would be mobility in the tooth also because the tooth has come out partially of its socket, and there is generally no pain on percussion. Intrusion, there is displacement of the tooth, but there is no mobility and there is definite pain on percussion because intrusion results in damage to tooth protective layer. What is the tooth protective layer if I'm talking about? The tooth protective layer is the pre-cementum that is present onto the outermost area of the root. So damage to the tooth protective layer, or we can say pre-cementum occurs. Pre-cementum occurs. Pre-cementum is the organic tissue, organic non-mineralized cementum that covers the outermost layer of the root. So whenever damage to the pre-cementum due to forceful entry inside the socket occurs, there are chances that tooth would undergo inflammatory root resorption. Okay, that's why intrusion is considered to be the most severe form of luxation injuries. And the clinically, what would be the outcomes, whether there would be displacement, mobility, pain on percussion, we have seen for all. What is the splinting protocol for luxation injuries? The splinting protocol, definitely concussion, there is no need of any splinting because there is no displacement or tooth mobility. In cases of subluxation and extrusion, the duration of splinting is 2 weeks. And what type of splinting would be there? So, a splinting should always be remembered in two aspects. What is the duration of splinting and what is the type of splinting? If I talk about type of splinting, again, it would be semi-rigid or physiological splinting. So, never rigid splinting is done for teeth. For lateral luxation and intrusion, the duration of splinting is more, that is 4 weeks. Again, it would be semi-rigid splinting or physiological splinting. The type of splinting always remains the same. Okay. This splinting can be done with various methods, like we can do braided stainless steel wire. We can use different ready-made splint. One ready-made splint that is available and physiological in nature is called TTS, that is titanium trauma splint. TTS, titanium trauma splint. Just like the arch bars are available for managing different forms of bone fractures and splinting of teeth, for dental fractures, there is a splint. A ready-made titanium spool is available like this, which is semi-rigid in nature. It can be cut in the desired length and pasted on the teeth for splinting with the help of composites. So it is called TTS, or titanium trauma splint, ready-made splint. It is a form of ready-made splint for this. These are the luxation injuries, important aspects. And the final type of injury is tooth avulsion. Tooth avulsion means the tooth has completely come out of its socket. It is also called exarticulation. Exarticulation of the tooth, avulsion. So, whenever avulsion occurs, the pulp necrosis is 100%. Definitely, the tooth has completely come out of its socket. So, there was complete sewerage of the blood in the nerve vessels. And what happens? There's necrosis in 100% of the cases. So, they always require root canals. Root canal or regenerative endodontic procedures, depending upon the maturity status of the tooth, because pulp necrosis occurs in 100% of the cases. Now, avulsion, the treatment considerations for tooth avulsion are decided by factors like, firstly, the most important factor is time between trauma and treatment. Okay. Optimal time, if I talk about, highest chances of success is 10 to 15, or I would say 15 to 20 minutes. The optimal time is 15 to 20 minutes. Okay. And maximal time is 60 minutes. So whenever we have to decide the treatment considerations, the time that we take into account is 60 minutes, whether the tooth has been out of the mouth for less than or more than 60 minutes. So what is the time frame that we use? 60 minutes. But if the question is asking what is the optimal time for the maximum survival potential of cases of tooth avulsion, that would be 15 to 20 minutes. The second factor that we consider in deciding upon the treatment is whether the tooth is open apex or closed apex. So we would say maturity status of the tooth. These are the two factors that we consider. It is open apex, immature tooth, or closed apex, that is mature tooth. So we look at the scenarios. The first scenario is time less than 60 minutes and the tooth is mature, that is closed apex. What would be the treatment? For this scenario, the treatment is simple. As the time is less than 60 minutes, the survival potential of the tooth is maximum. So we have to gently rinse with warm saline, warm sterile saline, and replant the tooth. Replant means place the tooth gently back into its socket. No special procedure is done for anything. Simply rinse off the debris from the tooth surface, from the root of the tooth, by warm sterile saline and replant. And once we replant the tooth, definitely it has to be splinted because the tooth has come out of its socket. What is the duration of splinting? It is 1 to 2 weeks, again of semi-rigid or flexible splinting. Okay. This is the treatment for tooth that has been out of the socket for less than 60 minutes and closed apex. But whenever the tooth comes out of its socket, it has to be stored in some medium. So storage medium, Hank's balanced salt solution is a specific medium, but it is less favorable than wire span. Okay, wire span, all of you know, is the solution, physiological storage medium for transporting the human organs. And wire span is the most favorable medium for storage of tooth also. If wire span is not there, the second best is Hank's balanced salt solution, HBSS. Then if we consider less frequent, it would be saliva of the patient. Next, less favorable is cold, low-fat milk. And least favorable would be water. So from most favorable to least favorable, this is the sequence of storage medium for avulsed teeth. Okay. Second clinical scenario can be time is greater than 60 minutes, but the tooth is again a closed apex or a mature tooth. But when the time is more than 60 minutes, the survival of this is an avulsed tooth that has come out and has been out of the socket for more than 60 minutes. These PDL cells, they become necrotic. Survival of PDL is least likely whenever the time is greater than 60 minutes. So they are removed by 5-minute immersion in 50% citric acid. 5-minute we immerse in 50% citric acid, that would remove the PDL, because these necrotic PDL cells, if are not removed from the tooth surface and the tooth is reimplanted as such, there would be onset of external inflammatory root resorption in the tooth. So it is important that when the time is more than 60 minutes, we remove the PDL by immersion in 50% citric acid, and then we replant the tooth gently, and then we splint the tooth. Splinting duration and nature remains the same. Okay. The third clinical scenario can be time is less than 60 minutes, but it is a case of open apex. Means immature tooth is there. So whenever the time is less than 60 minutes, open apex is there, we do nothing, no special treatment is given, replant, and then do regenerative endodontic procedures. We have to initiate regenerative endodontic procedures so that the tooth keeps on developing in a physiological manner. Again, splinting would be required. It remains the same as we have seen the clinical situations 1 and 2. The fourth clinical situation is the least favorable. Time is greater than 60 minutes. Okay, and again, it is a case of open apex. This is the least favorable outcome. Least favorable. We can just soak the tooth in doxycycline and replant it and splint it, but the chances of survival of such teeth, which are immature and the time has been more than 60 minutes, is least likely. Now, I have told you that in all cases of avulsion, especially in cases of closed apex, there would be a requirement for root canal therapy. So in the first stage, we definitely reimplant the tooth, and RCT is done after 1 to 2 weeks. But all cases would require root canal, and RCT is not to be done immediately. It can be done after 1 to 2 weeks when the splint is removed. Okay. When there is tooth avulsion with alveolar fracture, the alveolar bone is also fractured apart along with the avulsion, then there is 4 to 8 weeks splinting is given. Instead of 1 to 2 weeks, there would be 4 to 8 weeks of splinting. So only exception you have to remember for this is that in avulsion with alveolar fracture, what is the socket is also fractured due to. Okay, this is how the different dental traumatic injuries are managed. They are the important aspects of them. Okay. And choice of antibiotics. The choice of antibiotic is tetracycline because it inhibits osteoclasts and it also inhibits collagenase. Osteoclasts are the enzymes. Osteoclasts are the cells that would initiate tooth resorption. So, tooth resorption is inhibited by tetracycline. It has to be prescribed for 7 days, twice daily. Tetracycline isomer like doxycycline can also be prescribed, but they are the drug of choice. If we talk about outcomes of avulsion treatment. After reimplantation, the tooth may survive or it may not survive. The outcome, the most common sequelae can be external inflammatory resorption, EIR, external inflammatory tooth resorption. And another sequela is tooth ankylosis. So these are the two common outcomes. Which is the most common outcome of reimplantation or avulsion treatment? External inflammatory root resorption. The most common outcome is considered to be the failure of treatment Okay, and the less common outcome is tooth ankylosis, and tooth ankylosis is considered to be the success of treatment because a tooth which is ankylosed would survive for long duration. On the other hand, a tooth which has undergone external inflammatory tooth resorption would hardly survive for a couple of months. But EIR is the most common sequelae and it is considered to be the failure, and tooth ankylosis is a less common sequela and is considered to be the success of treatment. These are the different aspects of your dental traumatology. Important points I have covered. Now we switch over to the second section for today, that is some of the important questions from the previous years. Okay. Some recent INICET exam questions. The first question is displayed is, according to the Oxford scale, the highest level of evidence is given by systematic review with homogeneity of randomized clinical trials, individual randomized clinical trials, systematic review with homogeneity of cohort study and individual cohort study. So these are the different types of epidemiological methods. And highest level of evidence means the most scientifically predictable and relevant results they can be obtained with the studies, which are randomized controlled clinical trials with meta-analysis and systematic review. So systematic review and randomized clinical trials, they are the most advanced type of studies. Individual randomized controlled clinical trials, systematic review with homogeneity of cohort study. Now, cohort study, what is a cohort study? Cohort study means it is a futuristic study. I would take a sample of patients, suppose 3 or 4 patients of a particular condition, and initiate treatment for them. And we keep on following that group of patients. The group of patients that we have selected for a particular treatment are called cohort. And we keep on following those cohorts for a longer duration in the future. It is called cohort study. Cohort studies are a good form of studies, but not as good as randomized controlled clinical trials. And the top notch type of studies on the highest pyramid of epidemiology, they are meta-analysis with systematic review. So option one would be the answer over here, systematic review with randomized controlled clinical trials. It would be the answer. Okay. Question number two, after inferior alveolar nerve block, the pulp anesthesia develops 3 to 5 minutes after the block, 5 to 7, 7 to 10, or 10 to 15 minutes after the block. This is something that you have to remember, that pulpal anesthesia develops 10 to 15 minutes after inferior alveolar nerve block. If we talk about maxillary infiltration, if we talk about maxillary infiltration, then the duration of onset of anesthesia is 3 to 5 minutes. So option number one is, how much duration after maxillary infiltration, local infiltration, does pulpal anesthesia develops? 3 to 5 minutes would be for maxillary infiltration. The question is asking about inferior alveolar nerve block. The answer would be option 4, that is 10 to 15 minutes. Okay. Question number 3. The diagnostic test with least sensitivity is cold test, heat test, electric pulp test, or test cavity. As you can see, these 3 tests, or in fact all these 4, are pulp sensibility test. Pulp sensibility test. Pulp sensibility test means they rely upon presence of intact sensory nerve fibers of the pulp. Sensitivity is the ability of a test to find the disease, or there should be no false negative. A highly sensitive test means it has got less chances of false negative results. Ability of a test to find the disease is called sensitivity. So if we talk about compare the sensitivity of these tests, you have to remember the sequence that heat test is the most sensitive, followed by cold test, and followed by electric pulp testing. So which is the least sensitive test? Electric pulp test out of the three tests. So electric pulp test would be the answer over here. Least sensitivity. If we talk about accuracy of the test, these different pulp testing methods. What is accuracy? A test is considered to be highly accurate when it is highly sensitive and highly specific. Okay, so accuracy of cold test is highest, followed by electric pulp test, followed by heat test. So heat testing is the least accurate but the most sensitive method of testing. So please do not get confused. The question is asking which is the most sensitive method. If we talk about specificity, three diagnostic parameters we use for any test: sensitivity, specificity, and accuracy. The specificity of cold test is almost equal to electric pulp test and is greater than heat test. So heat test is the least specific and the least accurate test, but it is the most sensitive test out of the pulp sensibility tests. Question number 4. The critical apical diameter to obtain regeneration of the pulp tissue after tooth transplantation, replantation, or regenerative endodontic treatment is the critical apical diameter to obtain pulp regeneration should be 1 millimeter, 0.32 millimeter, 0.53 millimeter. Apical diameter does not matter. This is again something that you have to remember, that successful regenerative endodontic occurs when the apical diameter of the tooth is at least 1 millimeter. Would be the answer over here. See, immature pulpless teeth. Whenever there is a clinical situation of immature pulpless teeth, the treatment of choice according to modern protocols would be regenerative endodontic procedures. Now, technically, what is meant by an open apex or immature tooth? Whose apical diameter is greater than 0.7 millimeter. So you would take radiograph of a tooth, measure the apical diameter. Suppose this is a tooth. This is the root of the tooth. We measure this apical diameter. If it is greater than 0.7 millimeters, it is considered to be immature tooth. But whenever we are attempting regenerative endodontic therapies for successful ingrowth of blood vessels and nerve fibers, it is important that the minimum apical diameter should be 1 millimeter. So these are the two differences. What is the classical definition of immature tooth? 0.7 millimeters. What is the requirement for regenerative endodontic procedures to be done successfully? 1 millimeter. Question number 5. An effective pulpal soft tissue local anesthetic reversal agent is effective pulpal soft tissue local anesthetic reversal agent is diphenhydramine, hyaluronidase, phentolamine mesylate, and traneclopromine. This you have to remember that phentolamine mesylate 0.4 milligram. It is used as a soft tissue reversal agent after inferior alveolar nerve block. It is available in the trade name of Ora Works. See, the problem with inferior alveolar nerve block is that It provides pulpal anesthesia for nearly 2 to 2.5 hours, along with the soft tissue anesthesia of the same site. And this soft tissue anesthesia, which involves the lower lip and the tongue of that site, is very problematic and irritating for the patients, because even after the procedure, the patient may accidentally bite down upon the lip or the tongue without knowing that the trauma has been caused. So to prevent such untoward instances, we can use a soft tissue reversal agent, that is zero point 0.4 milligrams phentolamine mesylate. It is injected into the same site as inferior alveolar nerve block after the procedure. It is available under the trade name Boraverse. Question number 6. The occlusal reduction in teeth with irreversible pulpitis and mild tenderness on percussion. So what was the preoperative symptom in a patient? Diagnosis was irreversible pulpitis. The symptom was tenderness to percussion. And we have done the procedure called occlusal reduction. It increases the postoperative pain, decreases postoperative pain, has no effect on postoperative pain. In males, it decreases but has no effect in females. Now, this question technically can have two answers. Okay. Why I'm saying technically two answers? Because here it is simply mentioned irreversible pulpitis. Irreversible pulpitis and mild tenderness on percussion. So whenever this symptom is there, that preoperative tenderness on percussion is there, then occlusal reduction would decrease the postoperative pain. So 2 is the most suitable answer. Okay. When there is no preoperative tenderness, means if preoperative tenderness is not there but only irreversible pulpitis is there, then occlusal reduction would have no effect on postoperative pain. Why I'm telling you? Because you have to read the question properly. If both these two symptoms are given, irreversible pulpitis is a diagnosis with tenderness to percussion, it would decrease the postoperative pain. For this specific question, the answer would be option 2. If only irreversible pulpitis without any preoperative tenderness on percussion, it would have no effect on postoperative pain. So 2 set of questions, similar questions can be there. Question number 7. The best protocol for detection of vertical root fractures by using cone beam computed tomography is achieved at 0.125 voxel size, 0.2 voxel size, 0.3 millimeter voxel size, 0.4 voxel size. Now for the detection of vertical root fracture, okay, thickness should be twice the voxel size. What is the voxel? The imaging unit of cone beam computed tomography, CBCT. So voxel size, the minimum that is available is 0.075 millimeter. So VRF thickness should be twice the voxel size, means 2 into 0.075, minimum should be 0.15 millimeter thick vertical root fracture. So any vertical root fracture that is low, below 0.15 millimeter, cannot be detected even on CBCT examination. So what should be the requirement of thickness of fracture? Greater than 0.15 millimeter, that is 0.2 millimeters. 0.2 millimeters would be the answer over here. Option 2. Coming over to question number 8. The compressive strength of MTA can be improved by. MTA, you should remember that it has a disadvantage, that it has a very low compressive strength of 40 megapascals only. So we can improve by certain manipulative variables: ultrasonic agitation, application of a condensation pressure of 3.22 megapascals for 1 minute, condensing with a wet cotton by adding suitable additives. Out of these methods, it is best to use ultrasonic agitation, compact the ADTA under ultrasonic vibration is the best to increase the compressive strength, and it can be increased from 40 megapascals to up to 67 megapascals by ultrasonic agitation of MD. Question number 9. The higher incidence of vertical root fractures are seen in maxillary first molars, maxillary premolars, mandibular second molars, and mandibular premolars. Now, if we talk about incidence of vertical root fractures, the certain groups of teeth show more, like maxillary and mandibular premolars. Okay. Mesial root of mandibular molars and mesiobuccal root of maxillary molars and mandibular incisors. These are the 5 groups of teeth: maxillary and mandibular molars, premolars, mesial root of maxillary, mandibular molars, mesiobuccal root of maxillary molars, and mandibular incisors. These are the groups of teeth which most commonly show vertical root fractures. Now, out of these 5 groups, we can see both maxillary and mandibular premolars are there in the option. So, out of them, the best answer is 4, that is mandibular premolars, because as compared to maxillary premolars, mandibular premolars have a greater incidence of vertical root fracture. So, the answer would be this, mandibular premolars. Question number 10. In C-shaped configuration, the category 3 is again a straightforward question. You have to remember the classification of C-shaped root canals 1 through 5. Type 3 C-shaped root canals. 1 is a continuous C shape. Semicolon shape is type 2. 3 or 4 canal orifice is type 3. A single oval orifice in the center of C-shaped groove is type 5, and only a groove type 4, and only a groove with no visible canal orifice is type 5. Question is asking type 3, uninterrupted C with no separation, it is 1. Only one round or oval canal is type 4. 2 or 3 separate canals with both angles alpha and beta less than 60 degrees, type 3. And semicolon shape with either angles alpha and beta should not be less than 60 degrees is type 2. So answer would be option 3. Okay. Question number 11. All are features of referred pain, except which is not a feature of referred pain. See, what all of you know that referred, as the name indicates, referred pain. Suppose there is a pathology in one part of the body and the pain is felt in the other part. It is called referred pain. Okay. It is in a cephalad direction. Cephalad direction means from down above. Referred pain, mostly from the lower structures in the body, the pain is felt in the higher areas. Okay. Referred to higher areas. Definitely it occurs in a cephalad direction is true. It occurs in a laminated fashion. Laminated fashion means the body parts are divided into layers or laminations. Each is supplied by a different branch of a different nerve. Okay, so definitely it occurs in a laminated fashion. It is the pain that is felt in an area innervated by the nerve, similar to the one that mediates the primary pain. No, because referred pain is felt in an area that is innervated by a different nerve. Just like cardiac pain is felt in the jaw or in the tooth region, both are innervated by different nerves. So, referred pain is not felt in the similar nerve but different nerve. It can only be provoked by manipulation of the primary source of pain. True. Okay. If we keep on manipulating the area of the pain, the secondary source, it is not possible. So answer 3 is not correct. Is the option 3 is the answer over here. Is not a feature of referred pain. Question number 12. The success rate of inferior alveolar block in teeth with irreversible pulpitis can be. It can be increased by pre-medication with brufen and indomethacin, increases by doubling the quantity of local anesthetic solution, increased by using carbonated solutions, and success cannot be improved. Supplemental techniques should be employed. See, if it is a case of irreversible pulpitis, what happens in inflammation? There is release of prostaglandins. And these prostaglandins, when they are released, they sensitize the pulpal C fibers and the sodium channels. What is meant by sensitization? They fire at very low stimulus. Sometimes they cause spontaneous pain, and such teeth are difficult to anesthetize. So if we pre-medicate the patient with some non-steroidal anti-inflammatory drug, it would suppress the levels of prostaglandins. They are prostaglandin inhibitors. So they would inhibit the prostaglandins, and this inhibition of prostaglandins would reverse the sensitization of pulpal fibers and make them more receptive to the action of local anesthetic. So option 1, success rate of inferior alveolar block can be increased by pre-medication with brufen or indomethacin, which are both non-steroidal anti-inflammatory drugs. Would be the answer over here. Option 1. Question number 13. Precipitate formed on interaction between sodium hypochlorite and chlorhexidine can be prevented by intermediate flushes of. We know that whenever these two are mixed together, sodium hypochlorite acts like a base, chlorhexidine acts like an acid. There is an acid-base reaction which forms parachloraniline, which is a red color precipitate, which is insoluble in nature. PCA stands for parachloraniline. So these two reagents should not be mixed. There should be intermediate flushing with absolute alcohol. So sequence of irrigation is sodium hypochlorite, absolute alcohol, then chlorhexidine. First, second, and third rinsing we would do. Chlorhexidine would be the last, because we have to utilize the property of substantivity inside the root canals for chlorhexidine. So absolute alcohol would remove the residual sodium hypochlorite and prevents the formation of precipitate. Question number 14. Photon-induced photoacoustic streaming of PIPs utilizes which laser? Polonium YAG, helium neon, erbium YAG, or ND YAG? You have to remember this. We use erbium YAG laser for this with a wavelength of 2940 nanometers. If I talk about all these wavelengths, because laser wavelengths also they ask, ND YAG has a wavelength of 1064 nanometer. Helium neon laser is 632.8 nanometers, and polonium YAG laser is 2100 nanometers. All the wavelengths are in nanometers. But which laser is used? We use low energy erbium YAG laser of 2940 nanometers, and the device commercially is called Lightwalker. And the last question to discuss for today is, the rationale for a perpendicular root end resection is based on the following parameters, except it is more likely to include all the apical ramifications. It simplifies the root end preparation. Stresses generated during root end preparations are uniformly distributed, and it is necessary to gain adequate visualization and access. Okay, means during root end surgery, periapical surgery, there can be two methods of resecting the root end, from labial to lingual or palatal. One is an oblique resection, another is horizontal perpendicular resection. This is recommended and this is not recommended. So what is the rationale for perpendicular root and resection? It is more likely to include all the apical ramifications. Yes. What are apical ramifications? They are divisions of the main root canal into the apical one-third. Definitely a horizontal resection would include more of apical ramifications. It simplifies the root end preparation. Okay. The stresses generated during root end preparation are uniformly distributed is also correct. It is necessary to gain adequate visualization and access is also correct. And it simplifies the root end preparation is also correct. So which one is not correct? We have to select the best option that is least correct. So first, second, and third, they are all the best possible correct options for this. And it is necessary to gain adequate visualization and access is partially correct only. So would be the answer over here. At times, the options can be confusing. You have to talk about the best possible option. And here, the perpendicular resection is not necessary to gain adequate visualization and access. Okay. We can even go for a oblique resection, but oblique resection causes lesser favorable distribution of stresses. It exposes more of dentinal tubules and it is compromising more of the bone also because more of the bone has to be reduced to give an oblique access. So better answer is 4, which is not absolutely necessary. Okay, these are were some of the important questions that have been asked related to my subject in the previous INICET examinations. With this, I am concluding the today's session. I hope it has been proves to be fruitful to you all. My best wishes to you all for the forthcoming examination. Please study hard and do well. Thank you very much for being connected with me with this. I'm signing off. Goodbye and best wishes. Good night, everyone.